Welcome everybody. This is Doug McCall of the Canadian Association for School Health. Pleased to be welcoming people to this another session in our series of webinars that are being sponsored by the Canadian Drug Strategy of Health Canada, our association and our international counterpart and the Council on Drug Abuse are pleased to offer these sessions as a way of developing and accumulating knowledge in regards to school-based and school-linked substance abuse prevention. This particular session is one of 3 on instructional issues, and we're covering quite a macro to micro kind of a look at this issue today. Dan Reist from the Center for Addictions Research at the University of Victoria is going to be looking at some of the educational models or theories that underlie instruction and then describe how they've used that effectively in their instructional programs and their work with teachers in British Columbia and elsewhere. I'm going to provide a bit of an update or a bit of a report on the Canadian curricula that we had a chance to look at last summer for Health Canada for a small project, and to offer some observations about the time crunch as one of the key points I'll be making, but really to look at how we can take some of the large ideas that one of which Dan's going to be talking about into a context. And then Seth and Leslie from the Council on Drug Abuse are going to be looking at their practical experience in the project that's been funded by Health Canada and to look at how it really works out on the ground. As I said as we were waiting for the session to begin, in this introduction there are 2 links on the page to 2 similar web summaries, and we're hoping that people will find the time to go and look at those summaries. One's simply about a paragraph long, it's a glossary term as we've called it, and then another is about 3 pages long, of which we're trying to capture some of the ideas that we're going to be discussing today. So without further ado, I'm going to introduce Dan Reist from the Center for Addictions Research at the University of Victoria. And Dan is the Assistant Director for Knowledge Exchange at the Center. He leads a team that works out of Vancouver that focuses on communicating current evidence in a way that supports effective policy and practice. With a background in continental philosophy and, oh boy, this is a word, hermeneutics. Dan is quick to acknowledge that evidence is far more than statistics about patterns of use and harm, and includes attention to the ways we experience and talk about drugs and drug use in our cultures and community. So Dan has, for several years, contributed to policy dialogues in BC and nationally too, because I've worked with him on several national committees, and he's helped to develop BC's multi-systems approach to substance abuse. He's a champion of the careful use of language to describe substance abuse, and seeks to bridge some of the divides, the ideological and political divides that often undermine effective responses. Dan's interests include drug policy, health promotion, and the phenomenology of psychoactive substance abuse, and some of the philosophy of language and knowledge exchange. So Dan's got a varied background, and looking forward to his presentation today. Dan, if you wanted to click on your mic and take us through your presentation, that would be great.
Okay, thanks, Doug, and welcome everybody. And it is
Dan, I'm having trouble hearing you. Can you
okay,
closer to your mic?
Hello, is that better?
No, it's still not as good as when we tested it. Can you get real close, or try to drag the bar up in your you should see it up above your talk button. See if you can bring that up.
How's that? Is that any better?
Not good enough yet.
Something's gone wrong here with the technology.
I'm not sure why we're having this trouble, but maybe Dan, what you can do is go out of the session and come back in. Or why don't you test your audio now? Test your audio and see how that works. And maybe as we're waiting for Dan to do that, as a backup, I can go to
the audio,
some of the comments that I was going to make. But let's Dan, you'll have to click off your mic if you're going to do an audio check.
Okay.
Sorry, folks. We had pretty good sound before the session. So maybe what I'll do is go to a slide that I was going to use, and then Dan, please interrupt when you've tested your mic and come back in. But there is one slide in my presentation that I think will be useful as a bit of an introduction to what you were going to say. And this is one slide that I was going to use as a bit of a recall after Dan's presentation. These are some of the theories that guide curriculum development in education. We're in the document, the web summary I've referred to. You'll see that there are links to some of these concepts, but there are behaviorism is one strong approach to education, and that concept is really looking at teaching people quite specific behaviors, be they learning behaviors or health behaviors. And so that's one model that has dominated education quite a bit. Closely related to that is a cognitive model, which is, again, one that's been used widely, the knowledge-based, the learning of facts. That kind of approach to education has, again, dominated the educational scene for many decades, many centuries. I did note, and there's links in the document, to life skills. There's actually a lot of UN agencies have commented upon life skills as a skills-based approach, and so that would be good. Dan, do you want to try your mic now?
Okay, how's that? Any better at all?
It's still not good. Why don't you go out of the session and come back in and see if we can get a stronger connection. I'm not sure why it's not. Or maybe make sure your microphone is the jack if it's a connection that way, or USB port that is in the set. Make sure it's in the.
Yeah, no, it's solid.
Firmly attached.
Okay, I'll come back in.
Oh, okay. I'm hearing people are hearing you fine, Dan.
Okay.
So it must be something with my connection. I'll check my sound. Okay.
Okay.
So Dan, please go back. Please start up your session, and I'll figure out what's the problem with my sound.
Okay. Well, thanks, folks, for the patience on that, and hopefully everybody can hear me effectively now. I'd like to start with this little quote, just as a reminder to myself as much as to anyone else that in drug education we've been often guilty of assuming that we were offering effective answers when we were really offering simplistic approaches that didn't actually have effectiveness. And so when we started to get involved in the issue of drug education, and almost sort of kicking and screaming because we weren't very impressed with the potential effectiveness of drug education, but at the same time we're convinced that governments were investing in it. And so we started to think about, well, how could you do drug education differently? How could you do drug education better? But being very conscious that what we didn't want to do was simply offer another simple solution to a complex problem. So just keeping that as a reminder, it's helpful, I think, to think about what is the problem that we're trying to address when we approach this issue of drug education. And so often it's been framed in a problem-based framing, which we'll come to in just a moment. But I think we need to step back from that for a moment and just look at the broader issue. And that is that for thousands of years, people have been using these substances that we call psychoactive substances, and that they've been using them for various human reasons. And those reasons usually fall into a few clusters. We use them to feel good. We use them to feel better. We use them to do better, to enhance performance. And we use them for a variety of reasons. It could be called curiosity or the pursuit of new experiences, including spiritual experiences that have been often associated with substance use. At the same time that human beings for all of these thousands of years have been using psychoactive substances, people have also known the risks involved and the dangers. And so that has been reflected throughout the history of use. And those dangers or potentiality for problems really fall into, again, a few clusters: using too much, using too often, and using in the wrong context. So in a way, those two slides sum up the human problem related to substance use, that people use for lots of what we call human reasons, and there is a potential for harm. So the question then becomes, if we're going to design drug education, what is it we're trying to do? And I don't think we've often reflected long enough on that question. And so when we started to play with that, we began to say, well, drug education usually begins with a focus on the harm that must be avoided, coming from a sort of a medical model. We see a disease, we see a problem, and now we're going to fix it, or we're going to cure it, or we're going to prevent it. And the result of that has largely been that drug education is not grounded in educational theory. It's usually grounded in social marketing theory. We end up creating a message that we try to market to young people and get them to buy our message in order to prevent them from experiencing harm that we quite legitimately would like them to avoid. Now that may seem completely sensible, but if you actually go back and reflect on those previous two slides, and you realize that human beings use psychoactive drugs in order to enhance their state of physical, mental, emotional, or social well-being, what the World Health Organization defines as health. If people use drugs in order to enhance health, and yet our programs and services, including drug education, focus only on the harm, it creates this disconnect. And I think it is that disconnect that has been important in understanding, or is important in understanding, the ineffectiveness of traditional drug education. So we started to think, well, what kind of theoretical foundation should we be building on? And we began to reflect on, if instead of starting with a medical model approach to health, we actually were to start with a health promotion foundation, where the interest is not primarily about protecting people from a disease or a harm. Instead, health promotion puts the emphasis on enabling people to increase control over their health. So it's about building the capacity of people, as well as reflecting on the environment that is influencing people. So if we start with that kind of notion, instead of moving towards social marketing as the response, trying to sell people on a message, we really would start to look at building health literacy, because it's about enabling people to increase control. The way that they can increase control is through literacy. It's the whole foundation of public education in Western civilization. So what would health literacy, or if you wanted to define it, what would drug literacy look like? And literacy, if we go back to just our sort of fundamental definitions, literacy is really about appropriate knowledge and skills that allow people to do something, and in this case, to survive and thrive in the real world in which drug use is common. Now, it's important here to just recognize that literacy is a capacity, not an action. It's not we're trying to get them to buy something, to do something in particular. We're trying to build a capacity that allows the young person, or people in general, to increase control over their health, to be able to make the decisions that they would like to make, in an informed and a well-informed way. So we started with those kinds of principles at the foundational level, and then began to build, okay, so what does it mean to educate school-age children to take control of their health? And now the list that you see on the slide there is not intended to be comprehensive here, but to at least suggest some of the key areas that we need to think about knowledge around. So we need to help people understand the whole history of drug use and why it is that humans use drugs and what's going on in our bodies and brains that is driving that. So there's a whole knowledge base around the phenomenon itself, and that's far more than just teaching them about the risks. It's understanding the entire phenomenon so that they can put it in context, as it were. Of course, they also need to understand the impact that those drugs have on human functioning, and again, on the entire functioning, not just some pieces of it. So if we're talking about drugs that are being used for enhancement purposes but also have risks attached to them, we need to make sure that they understand the entire spectrum there and have a way to make sense of that and to use that. And then that takes us to kind of the whole knowledge around personal protective strategies. So if a young person is going to encounter these substances, they need to know what are the strategies that are available to them to protect themselves. And some of those strategies may be avoiding use, or at least avoiding use in certain contexts, etc. But also, if they do choose to use, what can they do that lowers that risk? How do they get the benefit without the harm? And so some of that needs to be part of the discussion. And then finally, they also need to understand the role that they play within the cohort of peers that they're part of, and how they can be active citizens within that cohort. And again, this is a kind of nuanced aspect. They could be agents for helping to reduce use within their cohort, but they could also be knowledgeable about how to respond to certain kinds of risks and harms. So for example, if some 15-year-olds choose to engage in drinking on the weekend, we would hope that we've given them some knowledge around personal protective strategies that they wouldn't choose to do it in a small boat out in the middle of the lake. We would hope that they would have an understanding of the recovery position, so that if one of their mates overdoes it and passes out, that they are not going to choke on their own vomit and die. These kinds of things are really important to the whole issue of taking control of health and so forth. So there's a whole range of knowledge issues that are from the phenomenon of what psychoactive drugs are and how humans have interacted with them, right through to very practical ways of making choices for oneself that are healthy and also minimizing risk and harm. And then along with that are a whole range of skills. And again, this is not a comprehensive list, but we need to be teaching our young people critical thinking skills, problem-solving skills, communication skills, and social skills to be able to navigate those social environments in which substance use is so deeply embedded. And then finally, I would argue that we need to help our young people develop a really good ability to deconstruct messages. And those, it doesn't really matter whether those messages are coming at them from the alcohol industry, for example, or from popular media, or even from health promotion people trying to sell them on a message. We need to help our young people have that ability to deconstruct those messages, make sense of them, and then apply them in their own lives. So that became the kind of mantra of objectives that we set ourselves. And again, remembering, I think it's good to pause at this moment and remember that quote at the beginning, that there's not going to be a straightforward, easy solution to all of this. It's messy stuff because we're dealing with the reality of human existence here. But if we try to oversimplify this and turn it into just a simple, let's just get them the message that will protect them right now, we will almost inevitably fail. So what we've done in our shop is to really then go and say, okay, if we were going to try to develop an educational strategy that would do what we've just been discussing, what would it look like? And we don't want to suggest that the only approach is what we've developed, but what we have developed is we've built it on a constructivist theory of education, which really basically says that knowledge evolves from the pre-knowledge, what somebody already has, and then by putting them in a context in which they can have new experiences and be exposed to new ideas and helping them develop the skills to process that, they evolve their own personal knowledge. And so it's not about simply giving people didactic principles, statements that they are to learn, to memorize, to somehow apply in their lives. It's really building on the existing knowledge and creating environments in which that can be developed. Now it's difficult to, and it's easy to think about how you might do that in some subjects. You know, you could play around in the chemistry lab in that way, but how do you do it with drug education? And I think one of the really powerful things that we have often missed is that there is an incredible amount of knowledge in the cohort. And we've tested this with classes as young as grade 4, and I suspect it's true of classes even lower than that if you were looking for the right thing, that the knowledge that young people need at any given level often already exists within the cohort. It doesn't necessarily exist within each individual student, but if you create the kind of context in which students can share the knowledge they have and learn the processes of critical application, critical thinking about it, you can advance the knowledge considerably without the injection of any new knowledge from outside of the classroom. But on the other hand, we're not limited to just the cohort knowledge. We've been using literature as a tool in schools for a long time to teach a lot of social issues, and literature is a rich source of information on drug use as well that we can use to introduce children to appropriate knowledge at various levels and get them to work with that knowledge, etc. So what is the advantage of this kind of constructivist approach? Well, it motivates students to think critically and become actively involved in the pursuit of knowledge because they are in control. They're starting with their own knowledge and they're in control of evolving that. It honors youth culture in a way that is not true of many other approaches, where if you just think for a moment about how we understand peer pressure in a drug education class, it's almost always perceived as negative, and yet peer pressure is a normal part of human socialization. And so if we are to turn that around and help people understand how we influence each other and not see it as just a negative, but see it as a process by which the individual can engage not only in receiving pressure but also giving pressure, and how to do that appropriately, it becomes a whole different kind of thing. And so we try to honor youth culture as part of the input that is positive but still needs to be critically evaluated. The other thing about constructivist approach as applied to drug education that I think is really important is that it allows the teacher to be a facilitator, not the expert. And that's it's always been difficult for teachers sometimes who are not necessarily trained in drug education to then teach drug education. And this actually, the teacher doesn't have to have a lot of background knowledge. They just need to be good educators at how to facilitate educational environments. And it's also compatible with multiple behavior theories. The little cycle on the side there is just the sort of frame that we've developed. We call it the 5 I's of iMinds. And it really just takes students through the issue of identifying the knowledge they have, investigating new ideas that are brought into the discussion through the cohort or through external sources, learning how to interpret critically that information, being able to project upon it through imagination. Where does it go? What are the implications of that? And how do you integrate it into your life? And that's a very quick snapshot of it. But that just gives you hopefully an idea of how a constructivist approach might work. Whoops. And what are professionals saying? Well, we've had actually very good response from school professionals across the board on the materials. That this idea of using, you'll notice in that second one there, referring to English 9, instead of teaching drug education as a subject area, we actually try to teach the knowledge and skills related to drugs in other contexts. So English using literature is an incredibly powerful resource, and so our grade 9 module uses short stories. So their students are actually learning all of the issues about short stories, but the short stories they're investigating all relate to substance use in various contexts around the world. We've got a grade 7 module that uses history as the focus point, but again, they're learning about substances that all of those ancient civilizations that they're studying in grade 7 socials are looking at anyhow. But interestingly, the normal socials curriculum has removed all of the references to drugs that were so much a part of those cultures. We've simply put it back in. So that's kind of the approach, and teachers, administrators are actually seeing the value of that and are quite excited about what's going on. And I think that's where my time is up, so I will quit.
Thank you very much, Dan. That was an excellent beginning, and we're going to come back to you in the next little bit to engage in a conversation about what some of the ideas that you've presented here. I'm going to quickly move through my comments, which are kind of more of a fact base and a little bit of a review. It's an attempt to look at those issues of scope, sequence, and time in the formal ministry in the Canadian context, but educational authority curriculum. And probably should pause and make a distinction between instructional programs, which bring, like Dan's, which bring together training and approach and materials and specific learning activities into a program of learning, versus a curriculum, which is, in the nomenclature that we use, is the formal mandated learning objectives that are stipulated by the educational authority, most often by education ministries for governments. Sometimes there are local variations, but it's by a mandated authority. And so that's a distinction to keep in mind as we look at some of the curriculum objectives that I'm going to identify. Purpose is to look at, to recall some of the conversations we've had already in this series, to review some of the approaches to education and from health that underlie effective health and personal and social development education, to present very briefly a compilation of potential learning outcomes or objectives that come out of those approaches, and then finally to illustrate how challenging it can be to include these objectives in a real-world curricula in Canada or in any other jurisdiction. Dan has very well presented one of the models there in terms of what have often dominated educational thought. And these models go back and forth. There was a time when basing instruction on multiple learning styles was a very big thing. It's faded a bit, but still is powerful. And brain-based and technology-based approaches are emerging as other, at least in the research that we watch constantly, are emerging as stronger influences on curriculum design. And each of those has a consequence in terms of the approach to a topic like drug education. And Dan has very well articulated how the constructivist approach can be built as a basis, not ignoring the others, but still being one of the primary design features. As Dan has already noted, there are many behavioral theories that are congruent with some of those educational theories, and we're not going to go into them today, but you can look at all those theories, and they're parallel to educational theories, and often some of them will connect with educational theories more solidly than others. If you look at, for example, self-determination or the cognitive behavioral approach that's quite consistent with the medical approach that Dan was talking about, or the social marketing approach that he was referring to. They're often used that way. I wanted to, as well, just to, before going into looking at curriculum, look at the types of methods that are used in education, in instruction, and you can see how many. This is actually an adaptation of a document for Saskatchewan from the Ministry of Education that produced it several years ago, but I found it the most useful listing of different types of instruction or learning, and you can see the many different things that can be used in teaching and in learning as methods. And so it's and of course most curricula encourage teachers to try to use as many different methods to reach as many different students as possible, but it's not always possible for teachers to have that many kinds of varieties of activities. In the project that we're engaged with CODA, through the Health Canada project, we've had a chance to update a database of lesson plans that we've maintained over the last several years. These are the areas that we have gathered up these lesson plans and educational resources. The database is simply creates links to these various resources, and these sections are the areas in which we categorize the various materials, and then we break it down by upper elementary or elementary, junior high, and secondary. And so you'll see how, if you look at some of those bold words, you'll see that they reflect much of what Dan was saying earlier. The connection with other subject areas is one that's jumping to mind there. There is, you can just look at those are not going to be surprising, I think, to most of us in the session today. But it's important to see the scope of it, the breadth of it, that is the point I'm going to try to make. As we try to, as we identified those areas, this is the first one, which is just the ground rules, setting ground rules, preparing students to discuss them. There are only two kinds of objectives we've identified in our database thus far. Those two objectives are fairly obvious, but minimal. But as you go through the various, and I'm not going to spend time in each of these slides, I'll give you a chance to read them. If you go through for example, this area of practical or functional knowledge, context specific, and as Dan has noted, and helping people work through those different contexts that they're going to encounter substances, you can see how quickly the number of topics multiplies. This is a knowledge section, but just providing that much practical knowledge it becomes challenging as you start to add up the various potential learning objectives, and each of these objectives eats up curriculum time. General and specific skills, again, you can see in each of these areas, when you're doing skills, you're going to probably need, teachers will have to spend more than one session in developing these skills. These are just a listing of the kinds of skills, and so you can see how the content can multiply when you when you look at skills, or if you look at health promoting attitudes or perceptions or normative beliefs. We had one of our earlier sessions had an excellent presentation from an expert on normative education or normative beliefs, and you can see how those can be again quite daunting in terms of the amount of learning that could be done in this area of drug education. And awareness of social influences, as many will know, is a traditional approach to not only drug education but tobacco and to other areas. And so although there are only about 10 or 12 objectives here, they are more than 10 or 12 lesson plans that might come out of that, obviously. Developing self-knowledge or awareness or self-concept, again, you can see the number of topics that can be dealt with there. Not all of them have to be dealt with within drug education, but it's important that they be covered somewhere because some of these will have an impact on substance use by young people. And again, it's you can see the number of topics. Being able to access social support, again, that's a skill base and an awareness base that needs to be built within the learner. And again, those are more lessons than those 5 objectives right there. Accessing health and addictions and other services, the different kinds of services available to young people, making them familiar with them enough to be able to access them, to be comfortable in accessing them. That's again, you can see the amount of content that can be dealt with there. Willingness to help others, again, the kinds of skills and attitudes and beliefs that come into play there, lots of topics there. And then these kinds of special populations need to be addressed in some way. Gay and lesbian youth and bullying has been a real focus on gay and lesbian youth recently, but the research is pretty clear that substance use and other health problems that confront those young people is also very powerful, and of course some of those other populations again. And so a curriculum needs to create the space in which, if that's relevant to the students in a class or in a school or in a community, that the curriculum needs to create space for those kinds of subject areas, those populations to be addressed. And then the last is, Dan's mentioned the one about using literature. There are opportunities in all of the curriculum and all of those different core areas. And so again, a curriculum can and should point the teachers to potentials for learning about substance abuse or health in those areas as well. So that's those are the outcomes, and then quickly to look at the time available. And these comments, and they'll be brief, is to look at the amount of time that actually is available for instruction. And there are different curriculum models. There's 4 described there. What we have often called health, which in other countries is called health, personal, and social development education, which is probably a little more accurate because some of these issues are personal development or social development issues. If you have a standalone curriculum at the junior high level, you're going to get probably around 70 or 75 hours worth of time of instruction. If you combine health and personal development with physical education, you're going to get about 1/3 of the time devoted to health, and so that results in about 24 hours. If you combine, and there are 3 jurisdictions in Canada that use that approach. If you combine health with career life or life planning, and there are other jurisdictions, most jurisdictions use this approach in Canada. If you're looking at life planning issues and career, you're going to probably be around 60 hours of instruction for what we might call health and personal and social development. And then the last model is there's one jurisdiction that has really just deleted health out of its curriculum and has got a phys ed program with some health considerations. And so you can see the little amount of time that's available for health and personal and social development issues in that curriculum. And so the time available is very important, because if you look at the number of topics that probably need to be looked at, and these are going to be considered by provinces as they develop their curricula, these are the many health and social issues that are going to be confronting young people at that grade level or age level. And you can see that there are many topics that need to be considered in the development of the mandated curriculum by an educational authority, and that provides a real challenge for curriculum developers. Very quickly to close, these are some of the things we found in a project that was really just a different kind of a project for Health Canada last summer. But we looked at how the different curricula in Canada were covering substance abuse and addictions, and no real surprises, I think. Alcohol is a focus, obviously, for the early junior high, tobacco being covered more in the late elementary grades, at least what we looked at. Social emotional learning, those topics are there. You can see that there was a fairly strong trend there. Item 4, most of the curricula include learning objectives that help students to know about the long-term health consequences. Those are the risks of drug use, alcohol, and tobacco use. Many of the curriculum documents include advice to teachers about teaching methods, suggesting portfolios and rubrics as ways to evaluate student progress, personal health journals kept by students. Those are recommending approaches to the teachers as they do the curriculum. One observation we made looking at it is many of the curriculum documents tended to generalize the learning outcome into a broader learning outcome without really doing justice to the amount of time needed to be able to take that broad area and break it down and teach it. I've sat on 3 curriculum committees in 3 jurisdictions in my career as an educator, and the compromises that are made often by bumping that up to a more general level and therefore making it harder for teachers to determine what specifically they should be teaching, and so they'll often be left with a very general set of outcomes which are challenging to measure and challenging to teach. Most provinces have a decision-making model in their curriculum, so curriculum developers or program developers need to be cognizant of that and to build around that rather than duplicating that. The content for the curricula at the junior high school level is very crowded, as one can note, and you can see how much focus there is on these days on bullying and on sexual health and personal and social development and so on. The note about which jurisdictions have combined with phys ed and or with career ed, you can see that the point I made earlier about the time available, it's really crunched when you're combining those topics with health or personal health education. Most of the curricula have a sequential approach to skill development through the grade levels, which is very valuable. So we need to build on that as we develop instructional programs so that it's consistent with the skills that are targeted for those grade levels. And the last point is the documents were quite varied in terms of the time frame in which they were published. It's a big job for a province to redo its curriculum, because the time frame to implement it is at least 12 years because as they roll it out. So the documents some of them are relatively new over the last couple of years, and some of them go back as late as 20 years, and those are the ones still in use. So the approach and the topics that are covered by health curriculum are going to be quite varied in these various jurisdictions. And that's quite challenging for teachers who are trying to keep up with the changing times and the issues that our young people are facing. If you wanted to go to the document, that database, you can find it on canadianschoolhealth.ca. I'm going to remind people about the Schools for All that has the web summaries here. But the point I think I'd like to leave you with is that the content that is potentially there for drug education and its related issues is very vast, and it's very challenging to cover that content when there are so many other issues crowding into the curriculum. So I'll move on to Seth. Excuse me, and Seth, if you could take us down to the front line and take a look at what you've been working with schools in several jurisdictions.
Hi everybody, my name is Seth, and like Doug said, I'm with the Council on Drug Abuse and the Programs Manager. And I'm going to talk about some of the real world, I guess, challenges or issues that implementing a comprehensive drug prevention program in the school system with existing curriculum, these are the different challenges that we encounter. So first of all, I'm going to give you just a little primer about our in-class education program, and then I'm going to go back and just talk about some of the different challenges that we have encountered. So CODA ICE, which stands for in-class education. Basically, we go into classrooms in grades 7, 8, and 9 3 times a year. These are full class periods, and we deliver drug prevention education. Each visit is built with an active learning approach to engage the students. So we have videos. CODA's produced their own Crossroads video series that deals with testimonials of youth from across Canada that have been We've had a really wonderful response from the youth with those. We also do worksheets, role plays, discussion, debates, and different activities. Here's just a sample of one of the slides from one of our programs, Stimulants. So you see we give the information, just the facts, but we also try to have some of that just the visual appeal to keep youth interested and keep them just engaged visually. So how ICE works. So each of these 3 visits per year has a different focus. And in order they are, the first visit is Drugs in My World, which heightens the awareness of drugs and how they interact with the youth's world. The second one is Drugs in Me, which the objective is like drug-specific information regarding interplay between drugs, the brain, and the body. So it talks a lot about the pharmacology of the drugs. We focus on the short-term effects. We talk about the long-term effects, but we always talk about the short-term with youth, just because it's that's real to the youth at that time. We also talk about withdrawal symptoms and even conversely talk about some of the perceived user benefits. So why do people take them with all these negative reactions and effects. And then the third visit is Drugs in My Strength, which focuses more on skills building and resiliency, so increasing the protective factors of youth and building their capacity to make healthy choices. So here is just some of the objectives, and I'll just use the grade 7 as an example. So the first visit, Drugs in My World, the objectives are to reduce risk factors by increasing knowledge, identify definitions of what drugs and drug abuse are. We talk about use, misuse, and abuse, and just some of the different criteria of those categories. We explore a lot of myths and misperceptions of drug use, and examine why youth use drugs and alternatives to using. The second visit, Drugs in Me, which was streamlining with the pharmacology of the drugs. It's just to reduce risk factors by increasing knowledge, the ability to categorize drugs into their particular classes. So we talk about stimulants, depressants, opioids, and just the differences of those drugs, and to recognize just the consequences of using some of those different substances. And the third visit, Drugs in My Strength, is to increase protective behaviors, demonstrate strategies that can be used to counter peer influences regarding drug use. So the first challenge that we found is the evaluative process. So I'm going to talk a little bit about the evaluative process of this program, which we're very proud to say is one of the most comprehensive evaluation processes for any drug prevention program out there in Canada. So the first thing is the CAB survey, which stands for Knowledge, Attitudes, and Behavior. And it's an evidence-based research tool that we use for our prevention program, in that before any drug prevention program is delivered, or any of the sessions have been delivered to the students are administered a CAB survey, which sort of gets a baseline of where their attitudes and their knowledge level and their current behaviors in terms of drug use and drug knowledge lie. So they get this at the beginning of the school year before any program delivery occurs, and then again at the end of the school year after that year's program deliveries have concluded, so after they've already had the 3 sessions. And the evaluative measures that we're observing are the claimed incidence of use of substances over the previous 12 months, the claimed frequency of use of substances over the previous 12 months, their personal forecast of substance use in the next 12 months, the probability that an offer from a friend would be rejected, and the advice to a closest friend to avoid substance use. And so over time, we want to observe these trends and these patterns, and it will allow us to ascertain just exactly how effective our drug prevention program is. Supplementary to the CAB survey, we also have what we call pre-evaluations and post-evaluations, and these are pre-delivery. So the pre-evaluation is delivered to the students before they're ICE visits. They're administered before visits 2 and visits 3. They're very short, 1 page, 2 to 3 minutes, and they provide feedback as to the information retention that the youth have had sometime after receiving a visit. So for example, some of the questions are, thinking back to the program session about, say, drug classifications that you participated in several weeks ago, here are some of the questions we would like you to answer. What do you consider were the main facts that the last session wanted you to know and understand? Were there any other facts that the session tried to present? And then please choose a phrase from those shown below to best explain how you have felt about the information presented and discussed in the last session. Is it strongly relevant to you in your life, mildly relevant, mildly irrelevant, and strongly irrelevant? So it just allows us to ascertain what knowledge the youth are retaining from the program, not directly right after they've received the program, but in subsequent weeks and months. And then conversely, the post-evaluation is completed right at the end of the visit, immediately after the session, and it allows us to look at the feedback that we're getting right away, how effective the program was, what their opinions and thoughts of not only the program but also the educator delivering. So I have a bit of a slide here that just kind of shows the life of the evaluation process through a school year. So the first step would be organizing school staff to administer the beginning of year CAB survey. Step 2, visit 1, the educator will come to the school, deliver the classroom period ICE delivery. The third step would be the evaluation immediately after the presentation, so the post-survey that I just discussed. And then the fourth would be organizing the school staff to administer the pre-survey. 5, that would be the second visit, and then so on and so forth, the evaluation post ICE delivery, and then organizing school staff to administer the pre-survey before visit 3. And then, right at the end of the year, organizing school staff to administer the end-of-year CAB survey. So here are some of the challenges that have occurred. So the CAB survey. Through feedback from students, teachers, principals, and school boards, we got the feedback that it was too long. Sometimes it was taking an entire class period to fill out, and different literacy levels sometimes played a part of that. We deliver our program in different areas of the country, so not every region, not every area, and even between student to student, different literacy levels. And some of the questions through feedback that we got were thought to be too intrusive. Competing with the rest of the school curriculum for class time. So with this CAB survey, we already had the school on board to allowing us to go in for 3 full class periods. But when we added the evaluation component, we were adding 1 class period at the beginning and 1 class period at the end. That was taking up to 5 class periods. And in some schools, that was a big ask. Not all. Some schools were more than happy to acquiesce that request, but like I said, not all. Another issue was teachers were not always informed adequately about the importance of the surveys or the delivery of the timing. And by not always informed adequately, it just became one of those circumstances where there was a bit of a broken telephone, in that I would have pretty good discussions with principals or whoever the school contact was about the program, and then as the program was relayed and filtered through person to person, sometimes some of the finer details about the evaluation and the importance of the timing sometimes got lost in the translation. So because of that, surveys sometimes were not being done before the scheduled visits. We would have an educator come in to deliver a session, and the pre-survey hadn't been administered or completed. The same with the CAB survey. Sometimes they weren't being done at all, and there was no time to reschedule. And then another issue was the surveys were being collected and then lost. So, for example, our post-surveys, after an educator would deliver a session, immediately concluding the session, they would hand out the post-survey, and as they were gathering their things and leaving, the students would fill the survey out, the teachers would collect the surveys, and then they were to take them to the office, where I would send a courier to pick these surveys up. sometimes these surveys were sitting in the teachers' desks for a little while. They were kind of getting lost in the shuffle. And then sometimes when they were delivered to the office, the secretary or the student volunteer, whoever was there, wasn't really sure what these surveys or these packages were, and subsequently they got further sometimes lost in the schedule or in the shuffle. So CODA's responses to some of these challenges. So we worked diligently with our funder and with CAMH, the Center for Addiction and Mental Health, to try and streamline the CAB surveys to reduce the class time required. So to shorten them, just to really take a good look at these CAB surveys and figure out, what is the most important information that we're trying to gather from these surveys, and try and stick with that, just to make the burden less on the schools as far as time requirement. We looked at the CAB survey further to simplifying questions to take the varied literacy levels into account. So looking at every single question and asking ourselves, is there an easier way to say this? Can we try and just make this a little more easy to understand? In terms of some of the broken telephone information issues that we were dealing with, we distributed a teacher one-page that previously was given to the principals outlining the program, but we decided that we were going to make sure that there was enough copies for every teacher so that at first glance they could take a look at the outline of the delivery, the evaluation process for the teachers, and all the administrative requests and requirements of the program. We started scheduling the CAB surveys like they were ICE delivery sessions. So when we would go to a school, when a school had accepted the CODA's programs, we would go to the school with the educator and we would schedule the 3 ICE visits, and they always went off like clockwork. How we first started doing was with the CAB survey. It was just a general consensus that one would be done at the beginning of the year, one would be done at the end. But I think without a firm date, sometimes they ended up getting lost in the shuffle, and there was, it made it a lot more sense just to schedule it as if it were a nice delivery. That way we know for sure that it was done. And we made CODA educators accountable for the collection of the surveys in sealed envelopes. Originally, we would have the CODA educators administer the survey. I'm talking the post surveys after the ICE session, and then as they were packing their stuff and leave, the teachers would collect it, because there was questions on there that actually asked for opinions and feedback about the educator themselves. So we didn't want to. We wanted to make sure that the youth knew that the educator wasn't going to see that, and we didn't want to vary any of their answers. So we would just have the teacher collect them, and then I would pick them up from the office. But because these were getting lost in the shuffle a lot of the times, we decided that the CODA educators would stay at the school. They would collect the post surveys, but they would put them in sealed envelopes so that they wouldn't get a chance to see it, but we could ascertain categorically that the surveys were in CODA's hands and they wouldn't get lost. Challenge. So administrator attitudes. So this is the second biggest challenge that we found. So by administrators, I mean principals. They could be vice principals, school boards. One of the issues was varied opinions as to what the drug situation in their school or community was. So this is more of an issue with getting our program accepted. I would do teleconferences with sometimes entire school boards and all the principals from each school in that school board, and it would be varied across the board as to their, I guess, opinion or the picture that they painted that the drug culture was in their community or their school. I've actually had, a lot of the times I get a guidance counselor that will come to me and really be looking for something, a good drug prevention education program for their school. They get really excited when I present how our program works. And then when they come back from their school board or their principal, sometimes the feedback is much different from what their feedback of the drug situation of their school is. So I actually got, and this is verbatim, one of the quotes is, "When students of this school get together after school, it's only to do homework, never to do drugs." I also get the viewpoint that if drug information is withheld, the youth will not know about the drugs and therefore will not use. So I think it's a kind of an old school kind of belief that what they don't know won't hurt them. So that's a little discouraging a lot of the times. Another quote that I got is, "We're afraid that if talking about these drugs is going to encourage youth to do them." And this is a real life issue that we deal with different school boards and different principals. And I guess the last one is turf protection. So it's apprehension on behalf of existing drug prevention organizations to partner or promote program resources. So sometimes there are different drug prevention organizations in different parts of the country that currently are doing some levels of drug prevention, and sometimes there's an unwillingness to either partner up or to work side by side to try and make sure that we're providing the most comprehensive drug prevention program available. So our responses to these challenges, trying to connect with a guidance counselor at the school or other contact who shares passion for drug prevention. So a lot of times a guidance counselor can kind of be our our feet on the ground running, that if within the school, if this guidance counselor really likes the program and what they see, sometimes they can be a good sell to the principal or to any other administrator. Encouraging those schools and administrators who are receiving CODA drug prevention programs to share their experiences with other schools and administrators. So a lot of times when we start into a new school board or different list of school communities, sometimes we just get into the one school to start with, and then through word of mouth and just through the experiences and working with CODA, the next year we get a lot more schools on board. So it's just trying to get into at least one school and then just let the program speak for itself. And third, partnering with local drug prevention and treatment organizations for actual delivery and to combat turf protection. So for example, in Saskatoon, we've partnered with the Saskatoon Health Region, which there's a drug prevention team there, so they're actually delivering CODA's program. And we find just having, it puts a lot of school boards and schools at ease, knowing that if we know the Saskatoon Health Region, and if they're buying into this program, then it must be a really good program. A third challenge is northern communities. So CODA's ICE program is delivered in 6 northern communities in Nunavut. So the program must take Inuit culture into account. And then there's just the geographical issues. So the travel for training and support, it can be inhibited by weather, cost, and just the sheer distance, as well as program materials. So surveys, curriculum, it takes much longer to exchange through Canada Post as opposed to couriers. So that poses some different difficulties. So our responses to these challenges, we ensure that our CODA ICE program is consistent with CODA Certified Education Advanced Modules, which is a series of modules that we've developed working across cultures and cross-cultural communities. So we make sure that our ICE program is in line with all of the principles in that program. And in response to feedback from Nunavut administrators, ICE will be delivered by Nunavut school teachers, Inuit leaders, or Inuit YAC members, as opposed to the rest of the country where we have an outside individual go into the school and deliver. We've received specific feedback that it has to be delivered only by these people, and that has to do part and parcel with number one, just working across cultures and cross-cultural communities, and that the elders need to be on board and approve the people that are delivering education to their youth. The third is conducting webinar and teleconference style training sessions in one community, Cape Dorset, and observe its effectiveness. We're trying to see if we can somehow eradicate some of the challenges that the tribal has by utilizing different technologies. And another example of utilizing technologies is using a Dropbox, a little piece of the internet where we can download all of our program materials and people can just download them from there. So that's something that's ongoing, and we're looking to see how effective it's going to be. So if there was any questions, I can definitely take them after this time.
Thank you, Seth. And sorry I didn't get a chance to introduce you. It was in the middle of a coughing session there. So Seth obviously works with CODA and is their program lead for their program that's going into across the country, and I apologize for not being able to introduce you to Seth at that point. Maybe to open up to questions, and if you have questions or comments, if you wanted to either click on the talk button, upper left-hand corner, or type in a question in the chat box in the lower left-hand corner, and I will read it out so we can talk about it together. Traditionally, this is a moment where people are pausing to figure out if they can ask a question in an environment like this. So please do. And maybe I could start with a question both to Dan and to Seth, and it's really about engaging teachers in this process. And I think we've now had examples of 2 instructional programs with different but compatible approaches. One is looking at a constructivist model, and one is really focused on the delivery by a trained educator, covering much of the same content in different ways though. And the challenge of engaging teachers who are so busy and so challenged by how much other content, what's been your experience? What seems to work best and what seems to be an ongoing challenge for you? So maybe Dan, can you respond to that question about how you actually engage teachers in your program?
Yeah, we have 2 examples. Well, one is the iMinds program, where we've actually had really good uptake from teachers, and I think the trick there is that we give them materials that they can use readily to do the job they're already doing. So it's like that English 9 curriculum in British Columbia. English 9 involves the study of short stories. We've simply piggybacked right on that, and the drug education is built into it. So I think that's one of the tricks there. On the other hand, we've developed a program on drugs and driving, which was quite innovative in that it was trying to use a classroom-based module linked to a community engagement piece. And while theoretically it has lots going for it, we have found that one very difficult to get actually implemented, because you've got to coordinate teachers doing a special piece of work and linking that with a community group to support that. And so just the complexity makes it more difficult. So I think the real trick is how can we build on and piggyback on what teachers are already doing and give them tools to do that and to effectively bring the drug education into it.
And Seth or Leslie? Great.
Sorry, just having some trouble with the talk button here. So my experience with the teachers is it's generally very favorable in that teachers they generally do want some specific drug instruction in that their curriculum mandates different health outcomes to be taught, but when it comes to drug prevention, it's nice that the curriculum is so like our curriculum is very laid out. It has lessons planned, so it follows a lot of what the existing kind of style of curriculum that they're used to teaching from. So I get a lot of really positive feedback about that, how much they like it, especially in the northern communities, because it really allows us to, like you said earlier, you may not be an expert in drugs, but as long as you can facilitate and you can stand in front of a classroom and read from a lesson plan and just knowing how to engage students and youth, that's pretty much half the battle.
Okay, and then maybe another comment which really comes out of the thoughts I was trying to present is the compatibility or the support provided by the provincial or territorial curricula for instructional programs like we've had. Linking these days, it must be linked to the provincial curriculum in order to be of interest to teachers. It's one of the pressures they face now as there's more and more focus. But is the curriculum helpful to you, or is it something that you need to be aware of, but you teachers and the programs tend to not focus on directly? Maybe Dan and then Seth, you could comment on that.
Yeah, I think the curriculum is helpful. I think the challenge, I think you outlined quite well some of the challenges of curriculum design and so forth, and that whole pressure to generalize, which inevitably is going to happen. I mean, as I was struck as you were going through your slides, Doug, just the incredible diversity of issues that are part of the thing. There's no way that if we took over the entire curriculum that we would be able to adequately do all of that. And so, of course, if a curriculum is designed to kind of touch on all of those things, it's going to become very cumbersome and difficult. I think the answer to that is actually to go with that generalizing tendency, but to realize that it's not about topics, it's about capacity. If we build capacity in young people, and that the curriculum is around capacity building, then they will be able to use that capacity to address whatever the topics are that are relevant in their lives. And so I think curriculum is helpful. I think the whole discussion around how to design curriculum is an important one, and one that needs more attention as we move away from specific content subject areas to capacities that children need.
And I completely concur that it's just about promoting resiliency, just a lot of those protective factors, just making sure that we're doing what we can to put those protective factors into place, or to at least identify with youth where those protective factors lie in their community. Because yeah, it can be very exhaustive if you start talking about drug abuse and different kind of offshoot issues that go along with that. At the real core of it all is just those skills, just the ability to deal with different influences, whether it be media, whether it be with your peers, and if you could build the capacity for those kind of issues, then the drug issues, you've got such a better chance and towards making healthy decisions for themselves. Just having that information coupled with those protective factors.
Okay, I see that we're running a bit over time, and so I'm going to move to a close for the session, and to maybe well, first of all, thank our speakers for their excellent remarks. And as I noted earlier, we're confident that the people in our over 90 people in this discussion group are visiting the pages and looking at the recordings and participating in that way. And I encourage people to please take a look at the written summaries and to add your thoughts. All of the versions of those documents are kept much like a Microsoft Word document, so not worrying about changing them. They won't be lost. And please go in and take a look at them and use that as a secondary way of continuing this conversation. I see that Michael from CCSA has offered to participate in that way, and that's great, and we'll look forward to working with CCSA on this. And maybe to maybe leave people with a thought and a little bit of an advertisement. I think it's in school systems, ultimately it's the teacher that makes the difference with the students, and so we need to be able to engage teachers and work with them in ways that are compatible with the pressures they face. But we also need to be cognizant of the systems that surround teachers, both in their school, and their school board, and their ministries. And I think Seth's comments of some of the concerns of administrators are part of that system response, and so we need to keep both a macro view as well as that individual help the professional in the front line kind of perspective, and so that's hard to maintain when you also have to get an instructional program in place and write materials and train teachers and train educators, delivery people, and so on. So it's a real challenge to be able to do both things at once, but I think it's very, very important. And maybe here comes the ad. We've had some scheduling problems with the webinars that's starting up in the new year. It's been primarily because of my poor health. It's with this terrible flu that's been going around. So but we'll be more on track. I seem to be coming out of it finally. And our next session is scheduled for March 4th, which is next Monday. We did have a session scheduled for later this week, which we've had to postpone because I'm going back to my American doctor, experiencing some of the healthcare here in the U.S. where I am spending winter. Anyway, we'll be Monday is the next session, and we'll be looking at teachers, but trying to look at what makes teachers tick in terms of how they look at issues, how they perceive, what's their work life like, what's their what are their professional norms, what are their concerns, and to try to understand teachers as a way of engaging them, as a way of helping them in their jobs and in their careers. And so that's kind of a different focus, but it was something that struck me very strongly when I was doing that project for Health Canada last summer, when we talked to teachers and about how they choose materials and choose to do things based on a variety of factors in their lives, work lives. And so I think it's really important for us to try to understand teachers. So we're going to have a really interesting panel of people from different parts of the world who have been working a lot in school health promotion in Canada. And then that conversation from those people is also connected to a discussion that's now worldwide and is being led by educators. Primarily, there's a very strong educational leadership organization out of the U.S. It's actually worldwide, but and most school boards in Canada belong to it, as well as around the world, 30 different countries, called ASCD. And they are taking a leadership role, and their advice is that we need to integrate within the education system. And so our session next week is going to be looking at teachers as being part of a system and how we understand teachers, but also how can we really integrate this stuff effectively within the educational system. So I'm very hopeful that we're going to learn a lot about that next week, and hopeful that we'll see all of you back then. So again, in thanking people, I'm seeing that people are already thanking participants. Thank you again for the presentations, both Dan and Seth, and looking forward to this ongoing conversation. So thanks again, folks. If you can, as you leave the session, please remember to go under File and choose Exit so that we can